Yes,
जी सर।
Saeed,
जी
can you
सर।
see the screen?
बिल्कुल सर।
Huh?
जी सर।
Okay, so that's okay. Okay, so whenever you want, we can start, huh?
जी सर, तो मैक्सिमाइज करें सर उसकी स्क्रीन को।
You got it?
जी सर,
It's
थैंक
okay now?
यू। जी सर, ओके नाउ सर। सर वी विल स्टार्ट अराउंड 9:10 PM after 4 minutes.
Okay, no problem.
सर इंट्रो स्टार्ट करें, आई थिंक, अगर आप अलो करें तो।
बिल्कुल बिल्कुल, आप बिल्कुल स्टार्ट करें।
थैंक यू सो मच सर। बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम एवरीवन। Welcome to all our participants again in this our second session of the module 6. And last time we covered the birth asphyxia, its pathogenesis and the diagnosis. And today we are going to discuss another most common topic, which is management of birth asphyxia without cooling, as a therapeutic hypothermia is not recommended for lower middle income countries. And this topic is today discussed by our speaker, Dr. Junaid Muhib Khan. And Dr. Junaid Muhib Khan is American board certified in pediatric and neonatal perinatal medicine. He is currently working as the director of medical education and senior consultant neonatology and associate director of residency program in SSMC Clinic UAE. He is fellow of American Academy of Pediatrics and fellow of the Royal College of Physicians, Canada. He is an active member of Committee of Neonatal Resuscitation Program, and he has vast experience in medical education, and he is a visiting faculty in Pakistan as well as in Canada. He has presented at many national and as well as international conferences as a speaker. Over to you, sir. Thank you so much.
Hey, Bismillahirrahmanirrahim. Thank you very much, Saeed, for your kind introduction, and thank you all the people, Professor Khalid Haq and all the senior member, and so Naveed also, and all the juniors to join. So we will start this topic. I have nothing to disclose except one thing, that I have no bias against therapeutic hypothermia. This is the standard management for neonatal encephalopathy and asphyxia. So, but the thing is that we have to prepare ourselves whenever some new technology or the new treatment come. Before we start, we have to look around ourselves, and then we will jump into that ocean, because there might be some side effects, there might be the outcome which are not that very great. So in this talk, I will try to answer some questions from the previous week. Last Saturday, there are some questions, and then we will see that how we can do without the cooling, how we can reduce the brain injury, and the outcome is what is the outcomes. So let's start. As we all know, the neonatal encephalopathy, what is the meaning of that? The epidemiology is already shared by Professor Sajjad last time. But you look in this data from Wales, where in 2007, 1 out of 10, and then it reduced to 0.5. In Netherlands, 1.56 to 0.86 by 2013. So it decreases. And these are the very high income, highly educated, and highly advanced countries. Wales is a part of UK, and Netherlands, of course, is Holland. So it is telling us something. Anyway, just keep it in mind for a while. So for all purposes, the definition of neonatal encephalopathy is disturbed neurological function. We are talking about 35 weeks and above, with abnormal level of consciousness and any combination of seizures, difficulty initiating, maintaining respiration, abnormal tone, reflexes, or disturbance of suck or swallowing. This is the definition suggested by McIntyre in 2021. So, just 1 minute. Okay. Now come to the data again in the higher income countries and the lower income countries. And this is by the pediatric in 2013. As you can see, the high income countries has a very lower rate, okay, of the HIE. More common in boys. So the white bar is the boys and the girls are the black bar. As you can see, the sub-Saharan Africa is a very high. South Asia is number 2, which is our region. East Asia, which is Malaysia, Indonesia, Java Islands, and Pacific. But surprisingly, you can see the Middle East also. Middle East, especially I'm talking about 2 countries, UAE and Qatar. They are very high resource, very high income countries. Qatar is almost number 1 or number 2 after Luxembourg by GDP. So why they are higher in this as compared to the other high income countries, as I showed you in Netherlands, Wales? There must be something going on here. Okay. So the reason is that I'm talking about again in these countries, the mix of population. There is a difference in population. In Wales and Netherlands, there are all Dutch and all English people there. Most of them, 98%. Here is totally different. Only 20-25% of the population is the local, and the other population mostly from India, then Pakistan, then Bangladesh, and Sri Lanka or Bangladesh, from the Southeast region. So we should keep in this mind that there must be some relation to the genes or the genetic or the incidence or the severity of the disease in our population as compared to the other. So the sentinel event associated with HI is maternal hypotension, cord prolapse, placenta, uterus rupture, and postnatal collapse. In addition to that, infection and inflammation. So we all know the high income countries 0.5 and 1.5 per thousand birth, and then they are recommended, and then n number need to treat is 7 to avoid 1 adverse outcome. But the problem is this: the people or the most of us are very excited about that. Look at that. Despite cooling therapy, 20% developed CP. Those without CP, up to 60% have cognitive impairments and behavioral problems. So this is very important to know in those babies who we are thinking we are cooling. The low middle income countries, you all know, is not recommended, and there are many reasons for that. There's a Helix trial, which is a very pragmatic trial, and you cannot ignore it. And the other trial so from many other places, and they said the cooling unlikely to be as beneficial in low middle income settings. The reason is, one of the reasons is that hypoxia may have started many hours before deliveries. And this is one of the things, biggest hospital in Lahore, I think biggest children hospital in Punjab or maybe in Pakistan, do not have the gynae of services there. So all their babies are transferred from somewhere. Those babies we don't know who's coming to the Lahore Children Hospital, that who resuscitate, what is the condition of the mother, how the mother transfer the baby or the father transfer the baby. There is no transport system. So the severity of the disease and the other auxiliary things around it is very, very different as compared to if the baby delivered in your center and you know that what is the resuscitation. How much resuscitation is important, I will just tell you in a minute. So look at this. This is the 2022 WHO classification, World Bank classification. Yeah, World Bank classification. The pink color is the low middle income. The dark pink is the low income. The light green is the, you can see my pointer also, somebody?
Yes.
Okay, I will just take up my other pointer, laser pointer. Okay. And the green one is the upper middle income, and the high income, the dark green. Almost all Africa are in the low income or the low middle income. Almost all Southeast Asia is the low middle income. And the Americas and the Canadas are all very high income. So the cooling in LMIC is different risk factor and timing of injury. That's the very important thing. Uganda published a study, infection, inflammation, increased risk in Uganda, and it can, have a adverse effect. Hypoxia may have started many hours before delivery. So this is also that you are getting the babies which are already severely damaged, and I think the cooling cannot be back. So that's why the cooling may not be as safe as beneficial in settings, especially with the seizures. Not only that, this is just published in 2019 that the systemic review for more than age for up to 60% cooled children show impairment of cognitive abilities. As you can see, the in this photograph or the MRI, that the connection it's reduced. Here also, if you can see, the green is a good connection, the yellow is not that very good connections. So despite therapeutic hypothermia, a high proportion of survivors still develop moderate severe disability. So I'm not saying that we shouldn't do it, we shouldn't try, but we have to have an environment for that. And I will tell you during this talk that what we should have if we really want to do it. This article is by Professor Neil Marlowe and Sita Shankaran, and it is available on the online. So the moderate or severe HAI we are targeting, okay, and this is some data you already know about that. Just for FYI, for your information, we are not cooling the baby less than 35 weeks. So the total infant and the screening criteria is the same, and the rate per 1,000 live births in the premature babies is something. It's just for your information. The question last week started about the Sarnet staging and the Thompson scores. And we already discussed that the Thompson scores are the numerical scores where you score, the higher the score, the sicker the baby. And the Sarnet staging is go by the mild, moderate, and severe. You can use this, okay, when you are treating the baby with HIE, and you can see that you have to examine the day 2, day 3, and day 14, and what are kind of the treatment you are giving, and you can have it both hand to hand, which give you a more better idea that if the baby prognosis is guarded, or it can have some good prognosis later on. Now, how should we define our skill in terms of deciding which babies with moderate, severe, and requiring? This is also, so how, that's why they think that in our setup in Pakistan, we don't have the training, the skills. And this is not that very easy to do the neurological exam, but we, of course, we have to train it. The other problem is that we cannot, okay, this is the criteria from the Toby trial. I will show our own criteria also, but anyway, this is the same criteria everybody know. We have to follow, and the C is the abnormal background. So the most difficult assessment is the neurological exam that define significant encephalopathy. The neuro exam should be performed 1 hour after birth, and you can assess it. Because it's an evolving procedure, every hour for the first 6 hours, we have to examine the baby. And then we should, before like 2-3 hours, we can decide if we're not sure that this baby we have to cool or not. So this is for that question, which we are in the gray area. This area, what we are using, infants more than 35 weeks with 1 out of the following 4, Apgar score less than 5 at 10 minutes, requirement of positive pressure ventilation at 10 minutes. Umbilical cord is less than 7 within 1 hour, base deficit is minus 16, or arterial blood within 1 hour of life. The infant has to meet the above criteria go for the second or severe encephalopathy Sarnet 3. And the third, we put them on age, then we will decide about that. Is less than 5 and more than 10. It has to be more than 5 and more than 10. But anyway, this is just for your information. Dr. give a very good lecture conference, and he can share with you. Criteria. Just age 35, birth weight less than 1800, abnormalities of cardiovascular system, sometimes diaphragmatic hernia requiring ventilation, or complex congenital heart disease, suspected neuromuscular disorder, or suspected chromosomal abnormalities. Sometimes it's very obvious, it's trisomy 13 or trisomy 18. Trisomy 21, we are still including in the cooling. Left threatening coagulopathy, imperforate anus, because you cannot put the probe, and we are not using the esophageal probe. Persistent pulmonary hypertension, you do the pre-ductal, post-ductal, and you know that you can suspect, but it is it's not the absolute contraindication, because now as the randomized controlled trials have confirmed that hypothermia would not worsen nor induce PPHN. So PPHN is not an absolute contraindication of therapeutic hypothermia. So we have a very strict inclusion and exclusion criteria for that. There is another question last week, that what happened if we cool the babies with the mild NE or mild neonatal encephalopathy? The answer is no, up to now. So a little bit neonatal encephalopathy is 50% of therapeutic hypothermia excluded mild. In the select those the highest risk, increasing any cohort studies that with mild any at risk of adverse outcome. And this is in 2013, but it is under mild neonatal encephalopathy is under studies. So these are the published in, by Conway in 2018. That if you can see, the favored the therapeutic hypothermia or favored no therapeutic hypothermia, it's no difference. So data available on 91 infants with the mild NE, abnormal outcome, schooled and uncooled 29 versus 37%, not statistically significant. Odd ratios are there. And so trend is towards the benefit, but it's not strong enough to guide the therapy. So individually, if the people want to do it, right now, the answer for the mild neonatal encephalopathy is no. So these are the few trials going on now. One is clinical trials and cool prime trials, comparative effectiveness, non-randomized cooling therapy versus normothermia. 12 center using the prime inclusion and primary outcome at 2-year Bailey. Another one is time trial, which is RCT of hypothermia for mild in California. Aims are the feasibility and 1-year outcome. And another one is COMET trial. I think this is from the Australia. Anyway, it's enrolling. So this is already these 3 trials going. So we will get more concrete answers to treat the baby with the mild neonatal encephalopathy with the cooling or not. So come back to our topic of the today. To prevent the intrapartum hypoxia, we have the prevention. Now the prevention is the thing. So we should start doing and having collaboration with our gynaecologists, because without that we cannot achieve the target. Screening for fetal hypoxia cases at risk, okay, intrauterine infection, meconium stain, obstetric history, all those we have to discuss, and they should, have a collaborative team so we can have a better outcome. These type of collaboration, I think, is going better first started at the tertiary care level in a very high settings like, children hospital don't have, but the, let's say, AKU, Indus Hospital, where they are both teams together and they can improve the outcome, because you cannot start improving the outcomes in the peripheries where even no ambu bag available. So that's my whole point, that start from the higher level, reduce the mortality rate there, and then you should be able to trickle down effect on that. Now, there are many things what we can prevent if you go through the this thing. Just 1 minute, I have to answer the phone. Hello. Yeah. Okay. So anyway, the maternal diabetes, as I said, gestational diabetes, this is very easily can be controlled during the pregnancy. Arterial hypertension, pulmonary cardiac diseases, maternal infections, anemia, drugs, maternal sedation. Drugs, before we thought it is the problem of the West, but no, it is the problem of the East also, and also the alcoholism. Anyway, uteroplacental pathology, cord compression, uterine malformation, and all those stuff which we can try to prevent. Fetal pathology, some of them we can and some of them we cannot. But the birth problems, most of it we can control, okay? Difficult deliveries, C-sections, unnecessary forceps, unnecessary, all these kind of a thing we can control very easily. So look at the OB factors and the outcomes. So variable associated with encephalopathy needing cooling. So multiparity, okay, pre-gestational diabetes, pre-eclampsia, those both we can control. Cesarean section only for distress. Schedule cesarean section, this, it is related that the baby need cooling later on. Ruptured uterus. Then variable associated with abnormal outcome at 24 months despite hypothermia is the preeclampsia, cesarean section, abruption of placenta, cord prolapse, and rupture uterus. So the gynae and the obstetricians has to take a role if we want to decrease this problem and mortality. Can we detect hypoxia? Yes. So we, even with the NICU fellows in our NICU here, we ask them to take a course and the training on the CTG. So it is very important. Okay, so as it's written here, a prolonged bradycardia more than less than 80 beats for more than 50 minutes, more chances that the fetus can be born acidotic. And this is the contractions and this is the heart rate, and you can figure it out. But the good thing about that again, that if you are doing the good CTG tracing, most of them in the green line, which is normal pH 7.25, baseline bradycardia, acceleration, early descent, only very few come less than 7.25. Similarly, yellow zone, variable deceleration, baseline tachycardia, loss of baseline variability, only very few come to the less than pH 7.25. But the red zone, yes, is almost 50-50, either the normal pH or the thing which is late deceleration, complicated loss of baseline variability, and complicated baseline tachycardia. And this is from the very old study, 1971. So it is still valid that if you are controlling and seeing and monitoring the CTG very clearly, then of course you will have a very good result. So these are the criteria and the neonatal sign consistent with an peripartum or intrapartum event. We already discussed about that. Now come to that what is we can do that if the we don't have the cooling and the cooling is not feasible, then what we should do about that. This diagram everybody knows. This is minutes, hours, days, and these are the injuries happen: excitotoxicity, oxidative stress, dysregulated inflammation, mitochondrial dysfunction, epigenetic changes, impaired neurogeneration and repair. So my focus is on acute brain injury protection, neuroplasticity bundle when the baby already compromised with this disease, then what we should do. But our focus is the acute brain injury protection. Initial steps, clinical stabilization and delivery. But the problem is that if the most of the baby transferred to you from the other hospital, then how you can control that? That's why I'm saying that even if you cool those babies, you cannot get the results which you want to have. But anyway, let's say the baby is delivered to you. So the first thing is the resuscitation. It is very important to have a very good skills, whatever the thing you are using, NRP, NLS, helping baby breathe. Professor Haq is online now. He himself did a lot of work, and with Dr. Irfan from Children's Hospital, and I have put a little bit my input on that, and we made a document and we published in this thing about, I don't know how many of you know about that, but that's the point, that you have to have very high level skills. You resuscitate the babies, okay? Simple steps to support airway and breathing manage most of the problems, believe me or not. I forget in my disclosure, these type of diagram, whenever you see during this talk, is by my friend called Dr. Satyan. I don't know, he has some program. His name is written here. He is very excellent in making these diagrams. He's in California. Anyway, so if you see the physiology of the baby at the time of the delivery, with some insult happening, it is better to aerate the lung and then cut the cord. So the delayed cord clamping is there. But the thing is that we become panicked. When the baby flight, they cut the cord and this thing. So the cord clamping after lung aeration is the key. And it will, as it shows that it improves perfusion. It's the key that you have to clamp the cord. So we already established a trolley which we go near the baby. We start doing the neopuff or the ambu-bag, whatever you have at the level of the mother abdomen, baby next to the mother, and then we will wait for 30 seconds to 1 minute, and after that we cut the cord. So the lung aeration is critical, but if the cord is clamped before the lung aeration, CVS compromise can ensue as a reduction in umbilicus venous return. Right. So the cord clamping after the lung aeration is the key. Now, as you can see here, the Katria, he did a lot of work in cord clamping and the cord milking. Now, what we want to achieve by delay the cord clamping, can we do in a hurry with the cord milking? Because we are talking about more than 35 weeks, not less than 20 or 35 weeks. So if we do the times milking, did it give the same effect which we are talking in that is a delayed cord clamping? In December, I will be in Hot Topics, and he told me he's also coming, so we will discuss about that. We have a roundtable discussion of some other thing, but I will put into this. So at this point, I don't know, but maybe it can have some effect. The importance of neonatal resuscitation skills. It is before the cooling era in the Chinese hospital. And just focus on the last two things, asphyxia incidence and the mortality from asphyxia in delivery room. From 7.5, the mortality decreased to 3.41. Only the, doing the correct NRP resuscitation. The asphyxia incidence decreased from 6.3 to 2.94. So that's why I'm saying start from the basic, okay? Cooling, inshallah, sometime we will reach there, but go from the basics. Good resuscitation help you out, and this is very well evident. Second, the respiration. Let's say you receive a baby from outside. Then the resuscitation part is over, so you cannot have a control. But the second issue in the respiration is the carbon dioxide. Low carbon dioxide in the associating C. So we have to maintain around 38, 45, okay, not less than or not more than 45, because the low carbon dioxide causes vasoconstriction, neuronal excitability, and you all know about that brain cell type. Okay, so we have to maintain it. This is article written by Muhammad Aldeeb. He was also one of our speaker in our conference. Side. Before we think hi-fi ventilators and this thing, please try to buy the blenders. All units should have the blend, because otherwise you end up with the hyperoxia, as you can see here, even for brief period. Hyperoxia, even for brief period, can induce oxidative stress. So the LCOR, you all know about that if 35 week and above, you start the resuscitation in the room here. If you don't have the blender, then you cannot know what type of what is the percentage of oxygen you are giving. 27% decrease in the short-term mortality about from that. Okay. here. While mechanically ventilated or not mechanically ventilated, you have to see the close attention to maintain normocarbia with the temperature corrected gases. What is the meaning of temperature corrected gases? Let's say if your unit has the blood gas machine, right, then you can do it. But let's say you have to send it, then you have to put it on proper on the ice. Otherwise, it will not give you the correct results. Avoid hypercarbia because, of course, it's increased CBF blood flow and risk of hemorrhage. Because the hypocarbia, which is also not required, and start the resuscitation. So these things which we can do. Very simple glucose level. Adequate nutrition and glucose control is important. Elevated or low glucose is aggravate the brain injury. The low glucose we mean in the red less than 2.6 as here. This is millimole, 47 around something you can calculate is the milligram per deciliter. More than 8 is the hyperglycemia millimole, and 150 milligram per deciliter. Hypoglycemia and association between hypo and hyper adverse outcome in the cooling as also hyperglycemia or glucose variability as and so the key is and the increase brain as much as possible. Nutrition